Hi guys, this is the last of a series of videos that I'm doing on HIV infection. So in my other life, I am an HIV researcher, and as such, I actually found it really difficult to kind of separate two, really key concepts to understanding HIV. And that's basically the clinical syndrome from the immune response. Because the target of the human immunodeficiency virus is immune cells, you really can't have one without the other. And when we actually look at the clinical syndromes, the clinical syndrome completely mirrors what's happening in the immune response. How many CD4 positive T cells do you have? How dysregulated are the other branches of your immune response? So when designing this video, what I decided to do is kind of do an overview of the immune response first, and how the virus affects it. And then we're going to do clinical syndrome and what I would expect immunologically at each stage. And then at the end of this video, if you want to kind of skip ahead, I do a short discussion on opportunistic infections and AIDS-defining conditions, as well as methods of prophylaxis. So prophylaxing for opportunistic infections specifically, but I also do a short discussion on HIV prophylaxis, which is also known as PrEP, pre-exposure prophylaxis. Okay, so this chart in one way, shape, or form exists kind of anywhere when you talk about HIV. This one is a fairly detailed one that includes both the viral load and the CD4 positive T cell count and the various clinical syndromes that can happen along the way, and antibodies. There are some that just include CD4 and virus, but this kind of version of this chart exists everywhere, okay? I like this one because it's pretty complete. We have both viral load, CD4, and just general T cell count, as well as antibody. But one thing I will point out is that the x-axis here is actually looking at months. Thankfully, these days, particularly with effective antiretroviral therapy, HIV is a chronic condition. It's no longer the death sentence that it was in the early times that we were aware of this virus and the disease it causes. I'll have a different one when I talk about the acute life cycle that talks about days and weeks, kind of what happens in those early events, but really we're talking about a many years long course here, okay? Now, the reason this is important is because generally stages of HIV are monitored based on how your viral load is doing and how your CD4 T cell count is doing. Okay, typically as viral load goes up, CD4s go down. That's kind of your general rule of thumb. Okay, even though the virus can infect cells other than CD4s, it's able to infect a lot of antigen presenting cell populations. Remember, when we affect CD4s, we essentially destabilize the entirety of the immune response, because CD4s are kind of the home and hearth of all things immunology. And yes, I'm a little biased being a T-cell immunologist, but it is kind of true. They're our main cytokine producers. So when we lose them, we lose the ability to communicate. Okay, so let's talk through what this chart is actually saying. All right, so let's say a patient is exposed to HIV and contracts it. That happens on day 0. Throughout the first month to 2 months, viremia is fairly low. It takes time for the virus to move from the mucosal site where the patient was likely infected into the antigen presenting cells there before being transmitted through the blood throughout the body. So if it started at, say, the vaginal mucosal site, moving into the GALT, the gastrointestinal associated lymphocytic tissue, or the brain, that's another place that we expect to find it. It's going to take a couple weeks to do all of that, all right? Over the course of 2 to 4 weeks, that's referred to typically as acute HIV. And that's typically where if a patient is going to show symptoms, they'll do so during those 2 to 4 weeks early on. But after that, the viremia continues climbing, and you're going to see increased viremia without treatment for approximately 6 months. The peak viremia, the highest amount of virus detected in the blood, is found sometime between 3 and 6 months post-infection. As viremia goes up, we see a corresponding decrease in CD4 positive T cells. Particularly CD4 T cell memory cells tend to be affected, but pretty much any CD4 positive cell can be infected by HIV because GP120 will bind to CD4 on all of these different cells. Okay, so we're going to see a significant decrease in our CD4 T cell count during the first 6 months of infection. So these numbers will go down sometime around 500 CD4 T cells per microliter. All right, maybe a little lower. Now, this is when something kind of amazing happens. The body, which hasn't really been putting up much of a fight for the first 3 to 6 months, suddenly starts fighting back, okay? So what happens is you start to regain your CD4 positive T cells. They start making an effective antiviral response. When they start making an effective antiviral response, you get cytokines. So you get interferon gamma, you get IL-12, you get IL-2, and with that, you get other things. You get macrophages, you get NK cells. With all three of them, you get CD8 positive T cells, which are capable of recognizing and destroying HIV infected cells. You get B cells to become differentiated into plasma cells, which are capable of secreting IgG. And this IgG can be neutralizing. So that's kind of a key point too. So now we have CD8s and we have neutralizing IgG. So we actually start defeating the virus a little bit. So what we see is that the viral load goes down. And when it goes down to the lowest point it's going to go down to in a patient, that is referred to as the viral set point. Patients with a lower viral set point do tend to have a better prognostic, future, better prognosis. That said, these days with antiretroviral therapy, our goal is always to get the viral set point in a patient down to undetectable, because obviously undetectable limits the ability of that patient to transmit the virus to another person, but also limits the damage that virus can do to our patient. So it's a win-win, okay? So as the virus goes down, our CD4s come up, our antibodies come up, our CD8s come up, things are going well. Except we haven't defeated it. We've just kind of fought it back. It's always going to be a chronic pressure. And here's the other thing I'll say about HIV. HIV is highly error prone. If you watch my video on viral replication, you see that HIV encodes its own RNA, its own reverse transcriptase. Okay, and this reverse transcriptase is incredibly error prone. It essentially enters 5 errors per genome for every virion that is made. So 5 different errors in every single genome. So this is big errors. What that does though is it creates an immune evasion strategy, because at this point these errors are going to be in the antigens that our CD8s and our antibodies are making. So over time our CD8s and our CD4s and our antibodies that we made that fought back this virus are now no longer effective. And the virus is going to come out of the reservoir, out of latency sites like the GALT and the MALT and the brain, and start replicating again with now these new neoantigens that our body is not prepared for. And basically, the long and short of it is that over time, we see this slow but steady depletion in our CD4 positive T cells. And eventually, even though we still have antibodies being made, they're no longer effective. And eventually, when they're no longer effective, the plasma cells that are making them die off and we lose antibody too. And part of the reason that happens is when we lose CD4s, we lose IL-2, we lose interferon, we lose IL-12. And so we don't have anything to support the B cells that might potentially help us make new neutralizing antibodies. At this point, We've left the clinical latency period where the virus and the CD4 were kind of at a truce, and we've moved into actual AIDS. And once you've moved into actual AIDS, you need to be concerned about AIDS-defining conditions, and you need to be concerned about opportunistic infections. AIDS is classified by raising or high viremia, CD4 counts below 200 per microliter, and opportunistic infections that we don't expect to see in healthy patients. So that's kind of the overview. So now I'm going to break this down into stage by stage: acute, clinical latency, chronic infection, and then we'll end this discussion with diagnosis and prophylaxis. Okay, acute infection. The first thing that I want to say that I want to make sure everybody is really clear on is this. If you have a patient who comes into your office and says, I have a fever and lymphadenopathy, or you felt lymphadenopathy, sore throat, history of diarrhea, myalgia, arthralgia, you can't hear those symptoms and say, it's HIV. You have to think of the whole clinical picture. It's not possible just on symptoms alone to look at a patient and say, this is HIV, or almost more importantly, this is not HIV. That's where you need diagnostic testing. However, that said, there are some symptoms that are associated with acute infection, which occurs in the first 2 to 4 weeks post-infection in most patients. This is sometimes referred to as seroconversion sickness or seroconversion symptoms. That's a little bit of a misnomer because it actually takes kind of a while to develop antibodies, but we'll talk about that in a moment. Okay, so patients will experience flu-like symptoms some of the time. Approximately 30% of patients experience symptoms like fever, lymphadenopathy, sore throat. There is this characteristic rash that sometimes shows up. It's a fairly common finding in symptomatic acute HIV. It erupts about 48 to 72 hours after the onset of fever, and it persists for about a week, 5 to 8 days. It typically covers from, the collar region, upper thorax, and sometimes the face, but we can see it move out into the extremities. Typically, it's these red color macules or maculopapules. Sometimes they run together. But the other symptoms are just kind of, fever of unknown origin symptoms: myalgia, arthralgia, diarrhea. Anytime you have diarrhea or nausea or anything like that, you might suspect some weight loss and headache. But they're all kind of non-specific, and only about 30% of patients actually report them. When you talk to patients, they say things like, oh my gosh, that was the worst flu I ever had. But they also say things like, I think I might have had a cold around that time. So it can be mild to very severe. It's kind of different for everybody. And approximately 70% of patients report nothing at all. They were completely asymptomatic. So that's why I'm saying you can't look at a person and say, they definitely contracted HIV. So what is actually happening at that time on a day-to-day basis? So we know that we don't hit peak viremia for 3 to 6 months. We know it takes time for the CD4s to rebound, but that they're decreasing. And we know that it takes time for those CD4s then to encourage CD8s and antibodies to actually be created against the HIV virus. So this is kind of, I like this because it kind of explains what is happening in that first month to month and a half of infection really well. And this is actually a really important window. We sometimes call this the seroconversion window, serologic window, the treatment window, diagnostic window. There's lots of different things, but it all really gets down to window. Okay, and this is the time between when a person is infected and when I can reliably detect antibodies in their serum. It doesn't mean that they aren't making antibodies. It's our ability to detect them that matters. Okay, so you get infected. You have these acute phase reactants, just like any infection. This is your innate immune response showing up. Innate immune response is going to have some cytokine expression: IL-1, IL-6, TNF-alpha. That's why we see that fever and lymphadenopathy, etc. Once we get that, we can start to get CD4s. But here's the problem. The CD4s getting activated can actually be a bad thing because that promotes infection. So even though they're going to start secreting cytokine, they're also going to start dying. So they're going to get infected, and many of them will die as a result of the infection. So what we see actually is a decrease of CD4s. And as we see a decrease of CD4s, more and more virions are released into the bloodstream, so then we can see increasing viremia. Over the course of 10 to 25 days, we start to see CD8 positive T cell responses to the original virus. So that takes longer than it does in most other infections. So we're out here at about 15 to 20 days before we're seeing reliable CD8 positive T cells. This is also around the time that we start to see antibodies. So enough CD4s are becoming activated and secreting cytokine to allow for the creation of non-neutralizing antibody. At first it's IgM because we don't have enough CD4s, and also it's always first IgM, but then eventually to class switch into IgG, right? And then we also have viral escape from the CD8 T cells that will eventually happen. So we get enough interferon and IL-12 to lead to CD8 positive T cells showing up around this time to the original virus. So we get increased, okay? But all of this takes time. So you first start making antibodies maybe around days 10 to 14, and some tests can detect them. But the majority of the tests we have can't reliably detect antibodies until 25 to 45 days post-infection. So that's why I say there's a prolonged seroconversion. So anywhere from 2 to 3 months is when we're really expecting to be able to reliably say with an antibody test, yes or no, you have HIV. So what are the ways we can do it? Largely by RT-PCR, and I'll talk about that more at the end of the video. Okay, now we're going to move into the phase of HIV known as clinical latency. This is kind of the sleeper phase of HIV. You have it, it's in you. You probably have viremia and are capable of transmitting it to others, but you probably don't have any real discernible symptoms that are appearing in any sort of pattern that would be concerning, okay? And this is where people wind up infecting others, and really where that reservoir of HIV infection is being utilized. Really, at this point, the virus and the CD4 positive T cells are kind of at a detente, where we're still seeing CD4s destroyed, but we're also seeing virus grow, but largely remaining stable. This period occurs early after infection, after seroconversion and establishment of the viral set point. So really, once you hit your viral set point, you're in clinical latency. And this is actually kind of what we're trying to get patients to at this point with antiviral therapy, and only because we currently don't have a cure for HIV. So at this point, just trying to get them to this point where they're not really feeling ill is our biggest goal. So during this time, viral load remains largely unchanged, but without therapy, most patients will move into AIDS in about 8 to 10 years. There are kind of two ways we think about it, asymptomatic and symptomatic, which sounds a little confusing, but I'll go into it. So asymptomatic, this is the majority of patients. However, sometimes patients have this persistent generalized lymphadenopathy. What this is enlarged lymph nodes in at least 2 non-contiguous sites other than the inguinal nodes for more than 3 to 6 months, okay? Because you can have a lymph node come up and come back down, you know, you're fighting something off. But if it stays, then that could be indicative of something chronic like HIV going on. Typically, the lymph nodes are symmetrical, modestly enlarged, mobile, painless, rubbery, and they tend to be located in the cervical, submandibular, occipital, and axillary chains. Those tend to be the sites. Now, what about symptomatic? Symptomatic is kind of a misnomer, okay? So remember, I said that during this phase, you know, your CD4s are still going down, but it's slowly, and virus is still rising, but again, kind of slowly, because we're kind of in this detente. As CD4s go further down, but before you've reached that level below 200 or below 500 that is associated with an AIDS diagnosis, You may experience some conditions more commonly than patients who have a higher CD4 count, like an immunocompetent individual. So these conditions typically present in patients with a CD4 count between 500 and 200, okay? There are things like thrush, which is caused by Candida, oral hairy cell leukoplakia, and herpes zoster, so basically viral infections that are already in you that your body is no longer able to control, so they're coming out of latency. Let's see, peripheral neuropathy. We can start to see the onset of hand, so not HIV-associated dementia so much, because that's more of an AIDS-defining condition, but maybe some minor cognitive motor disorders. And then ITP is the other one that we sometimes see in HIV-positive patients who haven't quite reached a CD4 count for an AIDS diagnosis yet, but are kind of on their way there. So as I discussed in the previous slide, in this stage of disease, which can last years, we're kind of in this détente between CD4s and viral load. There is a high rate of viral replication and destruction of CD4s. Something like 10 to the 9 CD4 positive T cells are destroyed per day, but we're able to keep up with it. So it's a slow and steady loss. Antibodies are present, but at this point they start becoming non-neutralizing. And remember, the reason for this is that the HIV virus is so error-prone due to the work of that reverse transcriptase that our antibodies essentially become outdated. They become ineffective. The CD8 T cells, it's a similar story. So MHC class 1 restricted HIV-specific CD8 T cells are present early in infection, and we can find them also in the chronic phase of disease. And we know that they play a role in helping to restrict viral replication. But we also know it's incomplete because we know that during this phase, we can see HIV viral loads between 10 to the 3rd to 10 to the 6th in blood. In untreated individuals. And if your patient is being treated and we're still seeing high viral load, they probably need a different medication course. Whatever you're working isn't working for them. So CD8s aren't controlling it as well as we would like it to. And part of that is probably also the work of the reverse transcriptase promoting immune evasion. And the other thing to keep in mind is that the CD8 T cells will not be able to detect latently infected cells very easily because they're not really showing viral antigens, and they may not be able to detect some of the other cells in the HIV reservoir that will reactivate when a patient goes off therapy. Okay, so following clinical latency, a patient may be diagnosed with AIDS. A patient is diagnosed as having AIDS when one of a couple of things happens. First off, the CD4 count falls below 200, or there is a presence of an AIDS-defining condition. So what are the AIDS-defining conditions? The AIDS-defining conditions have been described by the CDC and the World Health Organization. I've listed some of them here. A main one is actually wasting. Wasting is defined, and that's kind of what I'm showing here. Wasting is defined by the CDC as weight loss greater than 10% without cause, in the presence of diarrhea or chronic weakness and a documented fever for at least 30 days that is not attributable to any other condition than HIV. That said, if you have an HIV positive patient who's lost 10% of their body weight, can't really tell you why, you're probably going to consider that wasting whether they're reporting a chronic fever or not. A lot of factors have been associated with wasting, metabolic alterations, anorexia, malabsorptive disorders. There's also something that we haven't talked a lot about. Typically we talk about it with cancer. It's known as cachexia. Cachexia is basically the effect of too much cytokine in your system. So high TNF, high interferon can actually make you very nauseous and ill. So we try to avoid, when we see cachexia, we can also attribute that to wasting, and that could also be HIV associated. So there's a whole bunch of AIDS-defining conditions. It can include multiple or recurrent bacterial infections, recurrent pneumonia, candidiasis of the bronchi, trachea, lungs, esophagus. But here are a couple that I kind of just picked out that I know are big deal ones. So PJP, pneumocystis jirovecii pneumonia, that used to be one of the most common opportunistic infections in HIV positive patients. It still is a very common cause of disease in HIV positive patients, particularly those who have AIDS or are have a CD4 count less than 200. However, another one that's been coming up in kind of popularity is CMV, which obviously would be a reactivation because most of us are infected with CMV when we're younger, and then it goes latent and it reactivates. Coccidiomycosis, cryptococcosis, and toxoplasmosis. All of these are significant causes of disease in the HIV population, particularly neurologic disease, but we also see pneumonia with some of them, not so much toxo. Toxo is actually one of the main causes of meningitis and encephalitis in HIV-infected patients. Same with crypto. PML is actually a condition that results from reactivation of the JC virus in patients who have become severely immunosuppressed. Obviously, we always worry about tuberculosis in immunosuppressed patients. And then Kaposi sarcoma is actually a cancer that develops as a result of a herpes virus infection, particularly in HIV-infected patients. So if you have a patient with a CD4 count less than 200 who has one of these AIDS-defining conditions, then they would receive the diagnosis of AIDS. However, if their CD4 positive T cell count comes back up above 200 and they clear the AIDS-defining condition, their diagnosis would be downgraded from AIDS to chronic HIV, which obviously would be good news. Okay, so one of the things we want to do is we want to watch our patients for when they are at greater risk for conditions. We do that in a lot of different ways. In immunocompetent individuals, we think about vaccinations and public health initiatives and, not sharing needles and, things like that. And the same is true for HIV positive patients, but it actually involves the use of screening for known opportunistic infections that affect that community, as well as antimicrobial prophylaxis if needed, okay? So there's a couple that we kind of worry about in general and that we pay attention to. For example, if you have a patient who has recently received an HIV diagnosis, you're going to want to screen them for TB. So when you screen for TB in an HIV positive patient, you can do the TST, the tuberculoid skin test, or PPD skin test, however you want to refer it. Or you can do the quantiferon gold test, which is an in vitro assay. Either way, you're going to want to screen them for TB. Remember that an HIV positive patient may have a different induration or interferon response criterion for a positive test than an immunocompetent person. Okay, so what do I mean by that? If you're immunocompetent and you get a tuberculoid skin test, you need a pretty large induration for a practitioner to consider that a positive test. However, if you have HIV and your CD4 count is fairly low, that means your ability to make an induration is inhibited. So your induration size for a positive TB test would actually be lower to account for your lower CD4 potential. And the same is true for interferon if you're doing a quantiferon gold. So the criteria for testing a tuberculosis patient or an HIV positive patient for tuberculosis is different than the criteria for testing an immunocompetent individual. Coccidiomycosis, you're going to test even asymptomatic patients, screen them in endemic areas where you expect to run into coccidium. And so that would include places like Arizona, California. If you actually find a positive patient, you're going to go ahead and treat with fluconazole. If the patient's CD4 count rises above 500 or above 250 for more than 6 months, you can discontinue the fluconazole. But while they're low, you want to make sure to protect them because they're at an increased exposure risk for developing this condition. Pneumocystis jirovecii, as I mentioned, that was a huge problem in the HIV positive community. We're much more aware of it now, and we actually take steps to avoid it. So when a patient's CD4 count falls below 200, you actually go ahead and prophylactically treat with trimethoprim sulfamethoxazole. If their CD4 count rises for at least 3 months, then once again, you can go ahead and take them off the trimethoprim sulfamethoxazole, but you want to make sure they have a high enough CD4 count where they would be okay without it. I list histoplasma here. This one is not normally tested for or given, but it is one you want to keep an eye out for. If there's an outbreak in the community, you may choose to do some automatic screening for your HIV positive population, particularly if their CD4 count is very low. Once the CD4 count falls below 100, we're actually going to add on screening for toxoplasma and cryptococcus. So you'd go ahead and check the serology on your patient. If the patient is positive, you would use TMPSMX again. If you were already prophylaxing for pneumocystis, which hopefully you would be because that criteria is a little bit higher, then you're okay. Cryptococcus, you're going to screen actually patients in resource limited settings. And then if there's a positive, you would go ahead and treat with fluconazole. I also mentioned MAC here. This is a non-tuberculoid mycobacterium. Patients on ART are not normally given prophylaxis, but obviously if your patient is not on ART, we could see a situation where their CD4s would fall below 50, at which point you may choose to prophylax for MAC. Okay, so I just talked a whole bunch about prophylaxis for opportunistic infections for HIV positive patients. But what if we could avoid contracting HIV altogether? We don't currently have a vaccine for HIV, but what we do have is pre-exposure prophylaxis. Pre-exposure prophylaxis is essentially when we treat people who do not currently have the HIV virus with drugs used to treat HIV. Normally emtricitabine and tenofovir, which is an NRTI cocktail. The most common name for this is Truvada. That tends to be the one that is used the most. So who winds up getting this? Well, the whole thought behind it is to take it before you get it, okay? So this was pretty much used in HIV discordant couples. So one member of the couple has HIV and the other does not. So the patient who does not have HIV takes PrEP. Hopefully the patient who does have HIV is on antiretroviral therapy. In that case, the patient who does have HIV, if they're on effective antiretroviral therapy, their viral load is going to be very low to almost undetectable. And the patient who does not have HIV will be on PrEP so that if there is any breakthrough spike of the viral load in the HIV positive patient, the patient who is negative will not contract it. These days, it's not just used for HIV discordant couples. It's also used for high-risk individuals. So what is a high-risk individual? This would be somebody who engages in either sexual activity or IV drug use within a population that has a high risk factor for HIV positive. Often in urban settings, we see this in cities. So in this case, you have a patient who behaviorally is consistently putting themselves at risk for contracting the HIV virus. You may consider putting them on PrEP to reduce their overall risk of contracting it. There are benefits to this in that you can protect them from developing HIV. It's almost always, it's one of those cocktails that's largely supported by insurances. Medicare, I believe, and Medicaid currently support it because it's obviously a better, a positive, right? There are some downsides to it. First off, we're using two of our best drugs for treating HIV routinely and kind of, not consistently in patients who are constantly exposed to HIV but do not actively have HIV. So there is a risk of actually inducing mutations to these drugs, but the benefit to the HIV community kind of outweighs that risk. The other thing is you can't take it for life. It does eventually become toxic. Specifically, we tend to see some renal toxicity. So patients do need to be monitored on it to make sure that it isn't affecting them. You need to take it for, I believe, believe, about 7 days before it's actually effective at inhibiting HIV infections. There's also an education component when prescribing this to a patient. One of the questions I often get is that if it's so toxic, why are we able to give it to HIV positive patients? Well, once again, we're looking at a risks and benefits matrix here, that if you have HIV, you can't afford not to take emtricitabine and tenofovir, even if over time it does have drug effects on your body. Okay, so the immunologic features of HIV infection are really just one, but it's one that has a domino effect on the rest of the body. And the main thing is the CD4s are obliterated, okay? So if we take this CD4 cell here, it is capable of proliferation. If the virus is already within the cell, that means it is capable of creating a latency reservoir that is HIV positive. So that's how it can contribute to the reservoir. It also is capable of producing cytokines, IL-2, IL-12, interferons, as well as countless others, okay? With each of these, we affect the remainder of the immune response. We affect all lymphocytes with IL-2, right? So the growth of more CD4s, CD8s, and B cells, and NK cells. The 8s and the NK cells we would especially like to have when fighting viral infections. The B cells, eventually we would like them to make neutralizing antibody. But as these CD4s are depleted, we have less cytokine, so all of these facets of the immune system become dysregulated. And eventually that's what leads to basically the opening up of these patients to all of the opportunistic infections that we talked about in previous slides. There are also some direct effects of the virus itself. We can see the virus actually kill CD4 positive T cells. We can lead to ADCC of the CD4 positive T cell by NK cells when it's early on. We can also see complement activation. When the CD4 cells die via apoptosis, that kills them off, which is bad, but they can also die by pyroptosis, which is the inflammatory death, which leads to the secretion of cytokines, which you would think would be good. I was just complaining that there weren't enough cytokines, but really all this does is recruit more targets to be subsequently infected and then killed. There are indirect effects. Because it's a chronic disease, we're eventually going to see decreases in the cytokines. We're also going to see increases in expression of PD-1, CTLA-4, and other regulatory expression markers that can ultimately inhibit the responses of things like CD8s to virally infected cells. So all over the place, we're essentially just shutting down the immune response by getting rid of that cell. Okay, how do we diagnose it? To be honest, the serologic window complicates things. So for many diseases, we think we can test within 1 to 2 weeks. That's not necessarily true, although most patients will seroconvert by about 2 weeks. We won't actually be able to detect it for a while. So the first through third generation serology tests look for either IgG or IgM and IgG to HIV antigens. And most of those, you really can't detect anything for the first 30 days, okay? So at least 20 days, as far out as 45 days before it's actually effective at detecting the virus reliably. The fourth generation test is actually a pretty good test. And the reason is that this one doesn't just look for antibodies, it looks for antibodies and the P24 antigen. The P24 antigen can actually be found on the nucleocapsid inside the core of the virion. So in this case, you're actually looking for something associated with the viremia, which climbs a little bit more quickly. That we can start to use at 15 to 20 days post-exposure. So this is a good first step. That said, if you have a patient that was infected, maybe 10 days ago, they come in and they say 10 days ago, I had unprotected sex with somebody who has just disclosed to me that they are HIV positive, and I need to know as soon as possible if I have contracted this virus. In that case, your really only option is RT-PCR. You need to do genetic testing. The RT-PCR has a pretty good sensitivity. Within 10 to 15 days, you can do RT-PCR for most patients. There is an ultra-sensitive test that has a cutoff of 1 to 5 copies per mil. That can be done as early as 5 days post-infection. It's not commonly done, but it is an option. So for somebody who's very early in infection, RT-PCR is probably your best bet. The most common test used is still this 4th generation antibody antigen combination. The other thing I'll say in here with all of this is that if you're a healthcare worker who is concerned about exposure, exposure is kind of part of being a healthcare worker. Hopefully not for you with HIV. A lot of people have near-miss stories where HIV is concerned. If you're exposed at work, don't wait 10 days and get tested. Go and seek medical attention immediately. You'll likely be put on an antiretroviral regimen for a period of time. If you go and seek medical attention immediately that day, it's highly, highly effective. Very similar to patients that we put on PrEP to protect them. But this is how HIV is diagnosed in most patients. So if you go and get help immediately, hopefully you won't need to be diagnosed, but this is the testing that they might do to make sure that you are cleared.